Patient's here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
her left hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. Today is a big one. I'm sitting here looking at this stack of materials we've uploaded.
It's a mountain.
It really is. We've got textbook chapters on cellular regulation that seem to go on forever, drug monographs that look like they were written in ancient Greek, nursing care guides, lecture notes. Honestly, it's intimidating.
It is.
We are diving headfirst into pediatric hematology and oncology.
And it's a massive topic. I won't sugarcoat it.
Mm-hmm.
It's one of those areas in nursing school and in practice where the stakes feel incredibly high.
Right.
You're dealing with children, often very sick children, and the biology is complex.
Yeah.
But, despite the volume of information you're looking at, there is a very clear structure to it.
Okay.
If you know how to read the map.
And that is exactly our mission today. We are going to take this mountain of medical literature and we are going to apply the Pareto principle. We are hunting for the 20% of the information that answers 80% of the exam questions and, more importantly, keeps these kids safe when you're actually at the bedside.
That's the goal. And I want to frame this entire deep dive from the perspective of an exam coach.
Okay, I like that.
I'm not just going to read the textbook definitions to you.
Right.
That's useless. We're going to deconstruct why exam writers test certain things, what the specific safety traps are, and how to spot the patterns that repeat over and over again.
I love that approach because when I was reading through the notes on leukemia or sickle cell, I found myself just getting lost in the weeds of cell counts and protocols.
It's so easy to do.
So we need a roadmap.
Yeah.
You're saying we're going to start with what you call the master 80-20 map to find the big patterns.
Exactly. Find the patterns first.
Yeah.
Then we'll go system by system anemia, bleeding disorders, and then the big one, cancer.
And we have a dedicated segment on pharmacology called the Chemo Man, which I'm actually really curious about.
Oh, yeah. We'll get to him.
And then we'll wrap up with oncologic emergencies.
And throughout all of this, we have to keep one thread running through every single topic. Development. You cannot treat a child like a small adult.
Mm.
The sources are so emphatic about this. The disease impacts the child's development, and where the child developmentally impacts how we treat the disease.
So let's unpack this. Before we get into the nitty-gritty of specific diseases, you mentioned there are 4 mega patterns or buckets that pretty much everything in this stack fits into.
Right.
If I'm a student walking onto the unit, what are these buckets?
Okay, so if you step back from the hundreds of pages, you're really only looking at 4 fundamental problems. The first pattern is the something is low pattern. This is anemia.
Okay, red blood cells or hemoglobin are down. Simple enough.
On the surface, yes. But the exam decision point, the thing the test wants you to figure out, is why is it low?
Okay.
Is it a production problem? Is the bone marrow factory just not making enough? That's your iron deficiency or your aplastic anemia.
Right.
Or is it a destruction problem? Is the body making them, but then, chewing them up? That's sickle cell or thalassemia.
And clinically, if I walk into a room, what is the first thing I'm going to notice in a kid with this something is low pattern?
Brachycardia. That is your priority assessment.
The heart rate.
The heart is the engine. If the blood can't carry enough oxygen, the heart has to pump faster and harder to compensate. It's working overtime.
Okay, so that's the first vital sign I'm looking at.
Absolutely. You'll probably also hear a murmur because the blood is thin and turbulent. The kid will be exhausted, pale. But tachycardia is the body's primary distress signal.
Got it. Pattern number 2.
The bleeding pattern. This covers all your clotting disorders. The basic mechanism to stop bleeding is broken.
And the decision point for the exam.
The decision point here is distinguishing which part of the mechanism failed. Is it the platelets? The little first responder cells? Right. That's usually ITP. If it's platelets, you see superficial bleeding petechiae, those little red pinpoints, or purpura.
Okay, so skin level stuff.
Exactly. Or is it the clotting factors, the proteins that build the strong clot? That's hemophilia.
And does that look different to the naked eye?
Oh, completely different. Factor issues cause deep bleeding. We're talking bleeding into the joints, into muscles, deep tissues. It's internal. You might not see anything on the skin at first.
Oh.
And the safety can't miss rule for this entire bucket is simple. Do not traumatize the child.
Meaning what exactly?
No rectal temperatures ever. No IM injections unless it's an absolute life-or-death emergency. And strict fall precautions. Padded bed rails, grippy socks, the whole 9 yards.
Okay. Pattern 3 involves the scary stuff, the C word.
Yes. The mass or cellular chaos pattern. Neoplasms. Uncontrolled growth.
And the first signs are subtle.
So subtle. The priority cues are often things that could be anything else. Weight loss, pallor, maybe some swollen lymph nodes that don't hurt, or the silent abdominal mass.
And the safety rule here, and I cannot stress this enough, it was everywhere in the notes, relates to a specific tumor called Wilms tumor.
I saw that in the notes in all caps. Do not palpate.
Exactly. We'll get into the why later, but if you palpate that abdomen, you could kill the child. It is a never event. Wow.
Okay. And the fourth and final pattern?
The neutropenic pattern. This is immunosuppression, whether it's from the leukemia itself crowding out the good white blood cells or the chemo just wiping them out.
Right.
The decision point is that fever in a cancer kid is not just a fever.
It's an emergency.
It is a full-blown medical emergency. You have to treat it like sepsis until proven otherwise.
We have a specific number for the danger zone, right?
We do. An absolute neutrophil count, or ANC, of less than 500.
500.
That is the definition of severe neutropenia. If you see that number on a lab report, your radar needs to be on high alert.
Okay, so we have our 4 pillars. Anemia, bleeding, mass, and neutropenia. That actually makes it feel manageable.
It's the framework for everything.
So let's zoom in on pattern 1, anemia. And I want to start with a concept that I found fascinating because it sounds so innocent, but it's actually dangerous. The milk baby. The milk baby. This is a classic presentation for iron deficiency anemia, or IDA.
So paint the picture for me. What does this kid look like?
The paradox here is that the child, usually a toddler, looks chubby. They look well-fed. They might even be in a higher weight percentile.
So they look healthy.
They look like the picture of health.
Yeah.
But they are pale, almost porcelain-like, and completely exhausted. Listless. They don't want to play.
It feels counterintuitive, though. We're raised to think milk does a body good. You see a chubby, bouncing toddler, you think, that's a healthy kid. Why is that chubby appearance actually a warning sign here?
It is the classic deception. And this is where you had to think like a nurse and separate calories from nutrients.
Okay.
Cow's milk is high in calories and fat, which is why they bulk up. But it is virtually devoid of bioavailable iron. So you have a child who is calorically replete, but nutritionally starving for one specific critical nutrient.
They're full, but they're running on empty.
Exactly. And there's a mechanical issue here, too. Think about a toddler's stomach. It's small, right? It's the size of their fist.
Tiny.
So if you fill that tank with 30, 40, even 50 ounces of milk a day, which is so easy to do with a sippy cup they carry around like a security blanket, there is physically no room for broccoli or steak or iron-fortified cereal.
So it's a displacement issue. The milk is pushing the iron right off the plate.
That's factor 1. But factor 2 is where the exam writers will trap you. It's not just that they aren't eating iron.
Wait.
They are actively losing blood.
Wait, from the milk? How?
Yes, and this is distinct to cow's milk in young intestines. The proteins in cow's milk can actually irritate the lining of a toddler's gut. It causes a low-grade chronic inflammatory response.
Like allergy.
You can think of it like that, yeah. A condition called allergic colitis. It's not a massive hemorrhage where you see bright red blood in the diaper every time. It's microscopic, occult bleeding.
So the gut is just weeping blood.
And slowly, drip by drip, day after day. You're losing hemoglobin and iron in the stool, and it's invisible to the naked eye. So you have zero intake plus active loss. That is why these kids crash so hard and so fast.
That makes so much more sense now. So let's talk about the patho in plain language. Why does iron matter so much? I know it's for blood, but what is it actually doing?
Think of iron as the magnet or the glue. It's the core component of the hemoglobin molecule that physically binds to oxygen.
So it's the seat on the bus where oxygen sits.
Perfect analogy. Without iron, you can make the bus, the red blood cell, but there are no seats. The factory still works, but the cells it produces are useless. On a lab report, they're described as microcytic, meaning small, and hypochromic, meaning pale.
Little pale cells.
They can't carry the payload. It's like sending out a fleet of delivery trucks with no cargo space.
And this changes based on age, right? A newborn usually has iron. They don't come out anemic.
Correct. A full-term newborn has the maternal iron stores that they packed away in the third trimester. Those last about 4 to 6 months.
And for a preemie?
They missed that third trimester packing party. So their stores run out much faster, maybe around 2 months. That's why the age of presentation for IDA is usually later infancy or toddlerhood, once those stores are gone and the diet transitions to cow's milk.
So for the need to know, the 80-20 core for the exam, what are we looking for? What are the top findings?
Top findings: tachycardia and pallor, obviously. But look for the weird stuff, the things that make you go, huh.
Okay.
Spoon-shaped fingernails. The medical term is koilonychia. The nail becomes concave. And pica craving and eating non-food items.
Like what?
Ice is a classic one. But also dirt, clay, paint chips, laundry starch. If a parent says their toddler is eating the potted plant soil, your first thought should be to check a hemoglobin.
And the priority intervention, it's not a blood transfusion right away, is
But
it?
not usually. You fix the underlying problem. So diet first. You have to educate the parents. Limit that milk to 24 ounces a day. That is a hard number you need to know for your exams.
24 ounces. Got it.
Introduce iron-fortified cereals, pureed red meats, beans, spinach. But usually, diet alone isn't enough to replete their stores. They need oral iron supplements.
And I noticed in the drug guides, there are some very specific kind of fussy rules for giving oral iron.
It is fussy, but it's all about chemistry, and exam writers love this stuff.
So what are the rules?
Rule 1, give it with vitamin C, a little bit of orange juice, or some citrus fruit. An acidic environment converts the iron into a form that is much easier for the gut to absorb.
Okay, so OJ with the iron drops, what's rule 2?
Rule 2, do not give it with milk or antacids. Calcium is the enemy of iron absorption. It binds to it and blocks it.
Which is so ironic given the cause is often milk.
Exactly. You have to separate them by at least an hour or 2. And you have to warn the parents about the side effects, or they will stop giving it within a week.
What are they?
It causes GI upset, nausea, constipation. It can stain teeth, so you teach them to give it through a straw or a syringe aimed at the back of the cheek. And the big one, it turns the stool a tarry green or black color.
That's the good side effect, right? You want to see that.
It is. If the poop is black, it means the iron is being absorbed and processed. If the parents call in a panic saying there's blood in the stool, your first question is, what color is it? Black and tarry is expected with iron. Bright red is not.
Before we move on, let's circle back to development. How does this affect a growing brain?
Oh, it's huge. The brain is the most oxygen-hungry organ in the body. Chronic hypoxia in a rapidly developing brain leads to measurable cognitive delays and behavioral changes.
For how long? Is it permanent?
There are studies showing long-term impacts on math scores, reading comprehension, and even attention span if severe IDEA isn't caught and treated early. And then there's the physical aspect, the fatigue.
Right.
If a toddler is too tired to pull, to stand, to cruise, to run, and explore their environment, their gross motor development just stalls. They don't play, they don't learn from their environment. It has a domino effect.
Wow. Okay, let's shift gears from a production problem to a destruction problem. Sickle cell disease. This feels like one of the absolute pillars of pediatric nursing exams.
It's a major topic, for sure. Sickle cell disease, or SCD, is an autosomal recessive genetic disorder.
Meaning both parents must be carriers.
Right. Both parents carry the trait, and there's a 25% chance with each pregnancy that the child will have the full disease.
And the one-liner here, the core concept is the traffic jam.
That's the perfect visual. Normal hemoglobin, hemoglobin A, is in a red blood cell that's round, squishy, and flexible. It can squeeze through the tiniest capillaries with no problem.
Like a water balloon.
Exactly.
Yeah.
In SCD, the person has hemoglobin S. And under certain conditions of stress, when oxygen levels drop, HgbS polymerizes. It forms these long, rigid rods inside the cell.
And that's what stretches the cell into that classic sickle or crescent shape.
Right. And a rigid, pointy, crescent-shaped cell doesn't flow. It's sticky. It hooks onto other sickled cells. They clump, and they create a logjam that blocks the blood vessels. This is vaso-occlusion.
I want to pause on the word crisis, because in medical textbooks, we use that word a lot. Hypertensive crisis, thyrotoxic crisis. But in sickle cell, vaso-occlusive crisis feels like a sanitized, almost sterile way of describing something horrific.
It is.
What is actually happening inside the body to cause that level of pain?
It's a traffic jam, but that metaphor is almost too soft.
Yeah.
Imagine your blood vessels are a highway, and suddenly the road is blocked. Not with cars, but with concrete barriers. The blood flow stops completely.
Okay.
The tissue beyond that roadblock, whether it's bone marrow, muscle, or organ tissue, starts to starve for oxygen. It's ischemia. The cells are screaming for oxygen and they start to die.
Ischemia is tissue death.
Essentially, it's the exact same mechanism as a heart attack, but it's happening in your femur or your spine or your spleen. The pain isn't a simple ouch. It is bone crushing. Patients describe it as deeper and more intense than almost any other pain imaginable.
Which explains why our notes emphasize pain management so heavily. I was struck by the dosage recommendations here. We're not talking about Tylenol.
No. And this is a major advocacy point for nurses. There is, unfortunately, a stigma with sickle cell patients seeking opioid medications.
You hear about drug seeking.
Right. And you have to throw that out the window. You have to understand, this child is having a heart attack in their skeleton. We are talking high-dose IV opioids, morphine, hydromorphone, which is diluted, usually via a PCA, a patient-controlled analgesia pump.
And the absolute key for the exam and for real life is the schedule.
You don't wait for them to ask.
Never.
Never. If you see an order that says PRN as needed for a sickle cell crisis, you need to question that order. You are always chasing the pain. You need to be ahead of it. Scheduled, around-the-clock dosing is standard of care.
What about the triggers? The exam usually asks what happened right before the crisis, what pushes them over the edge.
We call them stressors. If it's anything that increases the body's demand for oxygen or alters their fluid status. Hypoxia is the obvious one. Dehydration is a massive one.
Why dehydration?
Because it makes the blood more viscous. It gets sludgy. It's thicker, which makes it even easier for those sticky cells to jam up. Fever or any kind of infection is a huge trigger.
And cold?
Yes, cold temperatures are a big one because cold causes vasoconstriction, which narrows the vessels and creates a bottleneck.
So for the 80-20 core, we have a kid who comes into the ER in a vaso-occlusive crisis. They are screaming in pain. What are our priority assessments?
A pain score is vital, of course, but you need to assess their respiratory status immediately.
Why?
We are terrified of a complication called acute chest syndrome.
Okay.
It looks just like pneumonia. They get chest pain, fever, a cough. They become hypoxic.
Right.
It's sickling in the vasculature of the lungs, and it is the leading cause of death in sickle cell disease.
Wow. What else are you assessing?
You also need to palpate the abdomen, specifically over the spleen in the left upper quadrant.
The spleen.
Splenic sequestration. This is another emergency. The sickled cells can get trapped in the spleen, causing it to swell up rapidly like a sponge.
And that's bad
because it pulls a huge volume of blood out of the general circulation. The child can go into hypovolemic shock in a matter of minutes. So if you feel a massive hard spleen and the kid is hypotensive with a high heart rate, that's a surgical emergency.
Let's talk interventions. There's an acronym here in the notes, HOP.
HOP. It stands for hydration, oxygen, and pain management. Some people teach HOP to it.
Okay, so hydration first.
Hydration is absolutely critical. We run IV fluids at 1.5 to 2 times the normal maintenance rate. We need to dilute the blood, make it less viscous, and help flush those sickled cells through the logjam.
What about oxygen?
Only if they're hypoxic. If their oxygen saturation is low, then yes, oxygen helps to reverse the sickling process. But giving oxygen to a kid who isn't hypoxic doesn't really help and isn't the priority. Hydration and pain control are the drivers.
And there is a specific drug warning here in the notes regarding pain, a big do not use E.
Yes, no meperidine. The brand name is Demerol. Do not give it. It has a toxic metabolite called normeperidine that can build up, especially with repeated doses. It's a neurotoxin. It lowers the seizure threshold and can cause tremors and seizures.
And kids with SED are already at risk for strokes.
Exactly. So we never use a medication that could further destabilize their central nervous system.
Speaking of CNS issues, let's talk about stroke. That's a huge complication.
It's a devastating complication. The sickled cells block the blood flow to the brain, causing an ischemic stroke. This is why we do routine transcranial Doppler, or TCD, ultrasound screening annually for kids with SED, usually from ages 2 to 16.
And what are you looking for with that?
We're looking for high-velocity blood flow in the cerebral arteries. If the blood is moving really fast through a certain area, it means that vessel is probably narrowed. That's a high-risk sign. And those kids might be started on chronic blood transfusion therapy to prevent a stroke.
And developmentally, how does a lifetime of this impact a child?
It disrupts everything. We have delayed physical growth and delayed sexual maturation because of the chronic anemia and poor oxygenation.
And socially.
Socially, it's incredibly isolating. These kids have frequent painful hospitalizations. They miss school. They miss birthday parties. It's hard to form and maintain peer relationships.
Is there an early developmental sign we should look for in babies?
Yes. In infants, the first sign of SCD is often dactylitis, also called hand-foot syndrome.
What's that?
It's a vaso-occlusive crisis in the small bones of the hands and feet. They get symmetrically swollen, red, and are incredibly painful. An infant who should be learning to grasp or crawl suddenly won't use their hands or bear weight on their feet. It hinders those early motor milestones right from the start.
Okay, moving to our second pattern, bleeding. Let's start with hemophilia.
The missing factor disorder. The classic genetics are X-linked recessive.
So the mom is the carrier and the son has the disease.
That's the textbook exam scenario. Yeah. Hemophilia A is a deficiency of Factor VIII, and that accounts for about 80% of cases. Hemophilia B, which is sometimes called Christmas disease, is a deficiency of Factor IX.
Can you explain the why briefly? Why does missing just one of these dozens of factors cause such a profound problem?
Think of the clotting cascade as a line of dominoes. To form a stable, strong fibrin clot, you need every single domino to knock over the next one in the correct sequence.
Okay.
If Factor VIII is missing, the dominoes stop falling right in the middle of the chain. You might form a weak little platelet plug, which is why they might stop bleeding from a tiny paper cut.
But it's not enough for a real injury.
Not at all. You can't form the strong fibrin mesh that's needed to seal the vessel and stop deep bleeding.
So that explains the clinical picture. It's not usually superficial cuts, it's deep tissue bleeding.
Exactly. The hallmark finding of hemophilia is hemarthrosis bleeding into the joint cavities. The big joints are the most common targets: knees, elbows, and ankles.
And the priority action when a kid comes in with a swollen, hot, painful knee.
RICE. That's the acronym you need to remember. Rest, ice, compression, and elevation.
Okay, RICE. Now here is the trick question I saw in the notes. Do you perform passive range of motion, or ROM, exercises during an active bleed?
My gut says no. If I move it, I feel like I might break whatever weak clot is trying to form.
Your gut is 100% right. Absolutely not. Why?
If you move a joint that is actively bleeding, you stretch the joint capsule, which increases the space for blood to pool and can dislodge any fragile clot. You immobilize it during the acute phase. ROM comes later, after the bleeding has completely stopped, to prevent long-term joint damage and contractures.
And the medical management is just giving them what they're missing.
Right. Factor VIII or Factor IX replacement given intravenously. The key exam tip here is to always administer the factor before any invasive procedure, even a routine dental cleaning.
Prophylactically.
Yes. And for mild hemophilia A, there's a drug called DDAVP, or desmopressin, which can be given. It works by stimulating the body to release its own stored Factor VIII from the lining of blood vessels.
Safety and education seem huge here. This is a lifestyle diagnosis.
It is. A huge part of the nurse's role is education. No contact sports, so no football, no hockey, no wrestling.
What can they do?
We encourage sports that build muscle without high impact. Swimming is perfect. Golf, jogging, tennis are usually okay. They need to use a soft bristled toothbrush to prevent gum bleeding, and they must wear a medical alert bracelet.
And there's a big medication class to avoid.
Yes, absolutely. Avoid NSAIDs and aspirin. So no ibuprofen, no naproxen.
Why?
Because those drugs inhibit platelet function. The kid already has a factor problem. The last thing you want to do is give them a drug that creates a platelet problem on top of it. Acetaminophen, or Tylenol, is the pain reliever of choice.
Developmentally, this must be so tough for toddlers.
It's a nightmare for parents of toddlers. Toddlers fall. That's their job description. So you see these little kids wearing soft helmets and knee pads just to play in their own living room. It's about creating a safe environment.
And for teens?
For the school-age kid and the teen, it's all about the struggle between autonomy and safety. Teaching them how to perform their own venipuncture and self-administer their 5V factor is a huge developmental milestone. It gives them control back over their bodies and their lives.
Okay, let's contrast that with our other bleeding disorder, ITP, idiopathic thrombocytopenic purpura.
Or immune thrombocytopenic purpura.
Or immune thrombocytopenic purpura. This is the viral aftermath.
What's the story here?
The story is almost always the same. A perfectly healthy kid gets a cold or some other common virus, they get better, and then about 2 to 3 weeks later, they suddenly wake up covered in bruises and little red spots.
What's the mechanism? Why does that happen?
It's a case of mistaken identity by the immune system. The immune system ramped up to fight the virus, but after the virus is gone, it gets confused and starts producing antibodies that attack the body's own platelets. It marks them for destruction by the spleen.
So the platelet count just plummets.
Yeah.
It crashes. We're talking below 20,000. Remember, normal is 150,000 to 400,000. And you see the classic signs. Petechiae, which are the little pinpoint spots, and purpura, the larger purplish spots.
But how is this different from, say, leukemia, which also causes low platelets?
This is a key distinguishing point for exams. In ITP, the child looks well. They're not acting sick. They're happy, running around playing, but they're covered in bruises. A child with leukemia is usually pale, febrile, lethargic, and has bone pain. They look sick.
And the treatment for ITP?
For many kids, we just watch and wait. It's often self-resolving. If the platelets are critically low or there's active, significant bleeding, we might give IVG intravenous immunoglobulin to basically distract the immune system. Or we give steroids to calm it down.
And you avoid platelet transfusion.
We try to. Because the spleen is primed to destroy platelets, if you give a transfusion, the spleen will just eat those new platelets immediately. It's like pouring water into a bucket with a hole in it. We only do it for a life-threatening hemorrhage, like an intracranial bleed.
Safe.
It's all about trauma precautions. No contact sports, quiet activities. But you don't need seizure precautions like you write with other conditions. It's strictly about not letting them bang into things until their platelet count recovers.
All right, let's move to patterns 3 and 4 combined. This is the heavy hitter, leukemia, specifically AKU and AML.
This is the most common form of childhood cancer. We absolutely need to spend some quality time here.
I feel like leukemia is a word everyone knows, but very few people really understand the mechanics of it. It's cancer of the blood, but what does that actually mean?
The one-liner you need to remember is bone marrow failure. That's the core concept.
Okay, explain that.
The bone marrow is the factory for all of our blood cells, red cells, white cells, platelets. In leukemia, one specific cell line, usually a lymphoid or myeloid precursor, mutates and starts producing blast cells.
Blast cells.
Blasts are immature, baby white blood cells. They are completely useless. They can't fight infection. They can't do anything. But they have one terrifying superpower. They replicate incredibly fast. I call them bully cells.
Why bully cells?
Because they don't just sit there. They take over the factory. They grow so fast and in such numbers that they physically crowd out all the normal, healthy cell production lines.
So the symptoms we see aren't from the cancer cells themselves, but from what the cancer pushes out of the way.
Precisely. This connects right back to our master map. The blasts crowd out the red blood cell production line, and what do you get?
Anemia. So pallor, fatigue.
Right. They crowd out the platelet production line, and you get
Thrombocytopenia, bruising, bleeding, petechia.
And paradoxically, they crowd out the production of mature, functional white blood cells. So you get
Neutropenia, high risk of infection.
So even if the lab report comes back and says the total WBC count is 50,000, which is huge, that kid is profoundly immunocompromised.
Because it's 49,000 useless blast cells.
Exactly.
Yeah.
They are cardboard cutouts of soldiers. They look the part on the roster, but they can't fight.
How do we confirm the diagnosis?
The gold standard, the definitive test, is the bone marrow aspiration and biopsy.
Where is that done?
Usually from the posterior iliac crest, the back of the hip bone. We're looking for the percentage of blasts in the marrow. A normal, healthy marrow has less than 5% blasts. Leukemia is defined as greater than 25% blasts.
That sounds incredibly painful.
It is uncomfortable, for sure. Conscious sedation is standard practice for kids. The nurse's role is critical in positioning the child, providing comfort, and then monitoring the site for bleeding afterwards.
And there's another diagnostic procedure that's critical, the lumbar puncture, or LP.
Yes, the LP is vital.
Why do we tap the spine for a blood cancer?
2 crucial reasons. 1, to check if the cancer has metastasized to the central nervous system, the CNS. We look for blast cells in the spinal fluid.
And the second reason?
To inject chemotherapy directly into the spinal fluid. This is called intrathecal chemotherapy.
Why not just give all the chemo through an IV?
Because of the blood-brain barrier, a protective layer that keeps toxins out of the brain, which is normally a very good thing. But it also blocks most IV chemo from getting in. So the CNS becomes what we call a sanctuary site. Leukemia cells can hide out there, survive the IV chemo that's treating the rest of the body, and then reemerge later to cause a relapse. We have to go in and treat the sanctuary directly.
Okay. Let's talk about the treatment journey. It's not just take a pill for a few weeks. It's broken into phases.
It is a marathon, not a sprint. Phase 1 is induction. The goal is absolute obliteration of the cancer. We hit them with a very intense multi-drug chemotherapy regimen to get the blast count in the marrow down to 0. This is when they are at their sickest, most vulnerable, and most neutropenic.
If they achieve remission, then what? Phase 2.
Phase 2 is consolidation, sometimes called intensification. This is designed to clean up any microscopic residual disease that might be left behind. And finally, you have maintenance, which is a less intense, often outpatient chemo regimen that can last for 2 to 3 years to keep the cancer from coming back.
I want to talk about the side effects from all this chemo. We mentioned moon face earlier from steroids.
Yes, that's from high-dose steroids like prednisone or dexamethasone. They are a key part of the chemo protocol, but they have major side effects. It changes their appearance, the chubby cheeks, weight gain, a buffalo hump on their back. For a teenager, this body image alteration is just devastating.
And it affects their mood too, right?
Oh, absolutely.
Okay.
It causes irritability, mood swings, insomnia, and a voracious appetite. They call it roid rage for a reason.
And infection control is the absolute #1 need-to-know priority intervention.
Without a doubt. Neutropenic precautions. This is the bubble boy concept,
Yeah.
but modernized for the hospital.
What does that entail?
No fresh flowers or plants in the room.
Mm-hmm.
The stagnant water and soil can harbor fungus. No raw fruits or vegetables that can't be peeled. Everyone who enters the room must wear a mask and practice meticulous hand washing.
And going back to our patterns, fever is an emergency.
Fever is an emergency. If a neutropenic kid spikes a temp, usually defined as a single temp greater than 38.3 C or a sustained temp of 38.0 C for an hour, you assume it is life-threatening sepsis until proven otherwise.
What's the protocol?
You move fast. You get blood cultures from all their central line lumens and a peripheral site. You get a urine culture, chest x-ray. You pan culture them to find the source. And you start broad-spectrum IV antibiotics immediately.
You don't wait for the culture results to come back.
You do not wait. Time is tissue. Time is life. You have a golden hour to get those antibiotics on board. You treat first, and you ask questions later.
Okay, that leads us perfectly into our pharmacology section. We call this the chemo man. This is a memory tool, right? A way to link drugs to their main side effects.
Yes, the chemo man is a way to visually map the specific high-yield toxicities of common chemo drugs to different body parts. The uploaded drug guides give us 4 of 5 heavy hitters we absolutely need to know for exams.
Let's start at the bottom with the bladder. Cyclophosphamide, brand name Cytoxan.
The target organ here is the bladder. The exam trap is hemorrhagic cystitis.
Bleeding from the bladder, what causes it?
This drug breaks down in the body into a toxic metabolite called acrolein. This acrolein sits in the bladder waiting to be excreted, and it chemically burns the bladder lining. It causes it to bleed.
How do we prevent it?
Prevention is key. Number 1 is aggressive hydration to constantly flush the bladder out. But the specific rescue drug, the antidote, is Mesna.
M-E-S-N-A.
Mesna. It binds to that toxic acrolein metabolite in the bladder and detoxifies it, rendering it harmless. So on an exam, if you see cyclophosphamide, you should be looking for answers that include Mesna and encouraging frequent voiding.
Okay, moving to the nerves. Vincristine.
This is a mitotic inhibitor. To understand its side effects, you have to understand how it works.
Okay, I remember mitosis from biology class cell division. How does stopping cell division lead to nerve damage?
This is actually fascinating. Vincristine works by freezing the skeleton of the cell, the microtubules. It prevents them from pulling the chromosomes apart so the cell can't divide. It stops the cancer from multiplying.
Okay, that's great for killing cancer.
It is. But guess what other system in your body relies entirely on those same microtubule tracts? Your nervous system.
Ah.
Your nerves use those same tracks as a railway system to send signals and transport nutrients from your spine all the way down to your toes.
So the drug can't tell the difference between a dividing cancer cell and a functioning nerve cell.
Precisely. It gums up the tracks. And that's why the signature side effect of vincristine is peripheral neuropathy. It attacks the longest nerves first, the ones reaching down to the feet.
And that's why we see foot drop.
Yes, that's a classic sign. The nerve signal just doesn't get to the muscles in the foot. The kid tries to lift their toes to take a step, and they can't. They might start tripping a lot. They might complain of numbness, tingling, or burning pain.
And there's a GI component, too.
Yes, for the same reason. It causes a paralytic ileus, severe constipation. The nerves that control gut motility stop firing. These kids need a proactive bowel regimen from day 1.
And there's a massive safety alert in the notes about this drug.
A huge one. Vincristine is a vesicant, so you have to watch that IV line carefully for infiltration. But more importantly, it is fatal if given intrathecally.
So it can never go in the spine.
It is for IV use only. If you accidentally inject vincristine into the spinal fluid, it causes ascending paralysis and destroys the central nervous system. It is an agonizing and irreversible death. Hospitals have multiple safety checks in place to prevent this.
Wow. Okay, noting that in big red letters. Moving up to the heart, doxorubicin, often called adriamycin.
The red devil. The target organ is the heart. The toxicity is cardiotoxicity.
How does it damage the heart?
It generates free radicals that damage the cardiac muscle cells. This damage is cumulative over a lifetime. So we track the total lifetime dose a patient receives. It can lead to cardiomyopathy and congestive heart failure, sometimes years after treatment has ended.
So we're monitoring for signs of heart failure.
Exactly. Edema, shortness of breath, crackles in the lungs, regular echocardiograms are part of the surveillance.
And it changes the color of body fluids.
It does. It turns urine and sweat a bright ruby red or orange color for a day or two after infusion. This is not bleeding. It's just the dye from the drug being excreted. You have to warn the parents and the child so they don't panic thinking they're peeing blood.
Okay, last one on the chemo man. Methotrexate.
A real workhorse drug in pediatric oncology. The primary targets are the kidneys and the reproductive system.
How does it work?
It's an antifolate. It starves the rapidly dividing cancer cells of folic acid, which they need to make new DNA.
And there's a rescue drug for this one too.
Yes. Leucovorin, which is a form of folinic acid. We give high-dose methotrexate to kill the cancer, and then we rescue the normal healthy cells by giving them leucovorin a few hours later. It's a very precisely timed dance.
And for nursing interventions, what's the priority?
Kidney protection.
Yeah.
Intense FAV hydration is critical, and we have to alkalinize the urine, usually with sodium bicarbonate in the IV fluids.
Why do we want alkaline urine?
We need the urine pH to be greater than 7.0. If the urine is acidic, methotrexate will crystallize in the renal tubules. It literally forms tiny sharp crystals like shards of glass and causes acute renal failure. So we're constantly checking urine pH.
That is a solid pharmacology review. Let's move to section D, solid tumors. We need to distinguish between two abdominal tumors that often get confused on exams, Wilms tumor and neuroblastoma.
Yes, let's set up a comparison table in our minds. First, Wilms tumor, also called nephroblastoma.
So a kidney tumor.
Right, it's a tumor of the kidney. The peak age is around 2 to 5 years old. And critically, it is typically unilateral. It arises in one kidney and usually does not cross the midline of the abdomen.
And the non-negotiable safety rule we mentioned at the very beginning.
Do not palpate the abdomen. You put a sign on the bed. You put it in the chart. You tell every single person who comes near that child, do not palpate.
Let's really break down the why. Is it because it's painful?
It's not primarily about pain. It's about containment. This tumor is encapsulated. It's enclosed in a thin, fragile sac. If you push on it, you can rupture that capsule.
And what happens then?
You seed cancer cells all over the abdominal cavity. You take a stage 1, easily treatable tumor, and you instantly turn it into a stage 3 or stage 4 disaster that requires much more aggressive chemo and radiation. You can worsen their prognosis with one push.
Now contrast that with neuroblastoma.
Neuroblastoma arises from primitive cells of the sympathetic nervous system. Most commonly, it starts in the adrenal medulla, which is that little gland that sits on top of the kidney.
And this one is different because?
Because it is a silent tumor. It's often called that because by the time it's diagnosed, it is usually already metastasized. It's a much more aggressive cancer than Wilms.
How does it look different on physical exam?
The abdominal mass itself often crosses the midline. Wilms tumor usually respects the midline because it's confined to one kidney. Neuroblastoma is more diffuse and grows across the belly.
And because it's metastatic, you see signs elsewhere.
Exactly. You see the classic raccoon eyes, periorbital ecchymosis, which is bruising around the eyes from orbital metastasis. You might also see bone pain from bone mets.
And the lab test is different.
Yes. The key diagnostic lab is a urine test for catecholamines, specifically VMA and HVA. Because this is a tumor of the adrenal sympathetic system, it often pumps out massive amounts of stress hormones. You'll need to do a 24-hour urine collection to catch these metabolites.
Moving up to the eye, retinoblastoma.
The eye tumor. The key assessment cue you need to know is the cat's eye reflex. The medical term is leukocoria.
What does that mean?
Normally, when you shine a light in a pupil, like for a photograph with a flash, you see the red reflex. In retinoblastoma, the tumor is growing in the back of the eye, and it reflects the light back as a white or yellowish glow.
And the exam trap here.
The trap is thinking that blindness or a painful red eye is an early sign. Those are late signs. The white glow, the leukocoria, is the early sign. Parents are often the first to notice it when looking at photos of their child. One eye is red, the other is white.
Okay, let's briefly touch on the two main bone tumors, osteosarcoma versus Ewing sarcoma.
Osteosarcoma is the most common. It typically occurs in the long bones, especially during the adolescent growth spurt. The most common site is the distal femur, right near the knee. On an X-ray, it has a classic sunburst appearance.
And the treatment is pretty drastic.
It often is. The tragic part is that it frequently requires amputation of the limb or a complex limb salvage surgery.
Dealing with amputation in an adolescent, that's a massive developmental and psychosocial crisis.
Huge. Body image is everything to a teenager. Your nursing care has to focus on that. You have to educate them about phantom limb pain, that it's real, it's not in their head, the severed nerves are still firing, and getting them connected with other teen amputee survivors is absolutely critical for their coping.
And Ewing sarcoma, how is it different?
Ewing sarcoma is a tumor of the marrow space within the bone. It can be in long bones, but also flat bones, like the pelvis or ribs. On X-ray, it has an onion skin appearance. The key difference is that Ewing's is very sensitive to radiation, so limb salvage is often more feasible than with osteosarcoma.
We're in the home stretch. Section E, oncologic emergencies. The you miss this, they die list. Let's start with tumor lysis syndrome, or TLS.
This is a metabolic emergency that happens when we start chemotherapy, especially for fast-growing, bulky cancers like leukemia or Burkitt's lymphoma. The chemo works too well, too fast. It kills a massive number of cancer cells all at once.
So the cells burst open.
They burst open, they lyse, and everything that was inside those millions of cells dumps into the bloodstream simultaneously.
What's in this chemical soup that gets dumped out?
Three main things you have to worry about. First, potassium. Cells are basically little bags of potassium. When they burst, you get sudden, severe hyperkalemia, which can cause fatal cardiac arrhythmias and cardiac arrest.
Okay, that's number one. What's two?
The breakdown of the cell's DNA releases uric acid, so you get hyperuricemia. This uric acid crystallizes in the kidneys, just like with methotrexate, and causes acute renal failure.
And number three?
Phosphate. Cells are also full of phosphate. You get hyperphosphatemia.
And because phosphate and calcium exist on a seesaw in the blood?
Exactly. When phosphate goes way UP, it binds with calcium and pulls it way down N. So you get profound hypocalcemia.
And what does low calcium look like?
Tetany. Muscle cramps, twitching, a positive Schwarzschick's or Trousseau sign. And if it's severe, seizures.
The intervention, what do we do?
We anticipate it and try to prevent it. Aggressive hyperhydration to flush the kidneys out. And we give a drug called allopurinol, which blocks the formation of uric acid. We're on strict INOs and monitoring those electrolytes every few hours.
We've already mentioned sepsis in the neutropenic child, but it bears repeating here.
Fever plus cancer equals antibiotics and no W. That is the mantra. Do not pass go. Do not wait for a full workup. If their ANC is low, they have no defense system. A simple bacteria can kill them in hours.
Just a couple of quick add-ins from the sources before we wrap up. Lead poisoning. I saw this tucked into the hematology section. Why?
Yes, because lead causes a type of anemia. It interferes with hemoglobin synthesis and blocks iron absorption. But the real danger of lead is neurological. It's a potent neurotoxin that causes irreversible damage to a developing brain.
Main sources we need to know.
Paint in houses built before 1978 is the big one. Also contaminated soil, some imported pottery or toys.
And the treatment?
Chelation therapy. A drug like Succimer is given, which binds to the lead in the blood so it can be excreted in the urine. But you have to monitor kidney function closely, because the chelating agents themselves can be tough on the kidneys.
And finally, testicular cancer.
This is a cancer of young men. The peak age is 15 to 35. This is why a key part of adolescent health teaching is the testicular self-exam, or TSE.
What's the teaching point?
We teach them to do it once a month, usually in the shower. The warm water relaxes the scrotum, making it easier to feel for any hard lumps, nodules, or changes in size. Early detection is key.
We have covered a marathon of content, from the milk baby to the chemo man. If we had to summarize the survival hierarchy for these exams, the things you absolutely cannot miss, what does that look like?
It looks like this, in this order of immediacy. 1, oxygen and hydration for the sickle cell crisis. That's an immediate life threat.
Okay.
2, safety and bleeding precautions for hemophilia and ITP. Prevent the injury. 3, infection control for the neutropenic and leukemia child. Protect them from the outside world.
And 4.
And 4, kidney protection. That means knowing your chemotoxicities and, for Wilms, do not palpate.
And bringing it all back to the human element, to the child in the bed, what's the final thought?
The final provocative thought is the concept of normalcy. We fill these kids with powerful drugs, we isolate them in rooms, we poke and prod them constantly. But the nurse's biggest and maybe most important developmental job is finding a way for that child to just be a child.
How do you do that?
Play is the work of childhood. It's how they learn and cope. So if they're too sick to run around, we find quiet play they can do in bed. If they're isolated, we use technology to connect them with their friends and family. We decorate their room. We maintain routines. We cannot let the disease and the treatment steal their childhood along with their health. That's our job.
That is the perfect place to leave it. To our listeners, take these patterns, visualize the chemo man, and go crush those practice questions. We'll see you on the next deep dive.
Stay curious.